Welcome to the Self-Medication Assessment Tool Training Program. The Self-Medication Assessment Tool is a comprehensive instrument intended to screen for medication self-management deficits in older adults and to facilitate targeted interventions. We'll begin the training with Module 1, which introduces and provides background information for the Self-Medication Assessment Tool, or SMAT. Part A of the module discusses factors that affect medication adherence. A person's capacity for medication management is defined as the cognitive and functional ability to self-administer a medication regimen as it has been prescribed. The majority of community-dwelling older adults are engaged in the self-care activity of managing a medication regimen. It has been estimated that 35 to 60% of people do not take their medications as prescribed. Drug-related problems are reported to be a major or contributing cause of about 19 to 28% of hospitalizations in people over age 50, increased emergency room visits, and increased need for assisted living arrangements. Many factors affect long-term adherence to medication therapies, including patient factors, medical and treatment factors, and system barriers. First, there are several patient factors that have been identified to influence medication adherence: age, physical and sensory factors, memory and cognition, and attitudes, beliefs, and preferences. The first patient factor is age. Adherence has been found to differ across older adult age groups. Adults between the ages of 65 to 74 have the least errors, while adults ages 75 and up have the most errors. The young older adults are thought to perform better because they are less busy and their routine activities allow for planning and use of memory aids, and also because healthcare is a priority in this group of adults. Increasing age can affect medication adherence for several reasons. First, physical functional capacity is often impacted. For example, arthritic conditions can make it difficult to remove medication from packaging. Second, with increasing age, there can be impaired drug metabolism and unique sensitivity to the effects of the drugs. And third, increasing age can impact cognition, mobility, and memory. And finally, fourth, there are often sensory and acuity changes with increasing age. For example, vision may decrease, resulting in a need for 12-point or larger font and high contrast text on labeling. In hearing, the loss of the ability to hear high-frequency sounds affects language comprehension. Therefore, older adults function best with a low-noise environment and low vocal tone. Memory and cognition factors can also impact a patient's medication adherence, a complex cognitive task that includes understanding the instructions, making a plan of action, remembering what to do, remembering to do it, remembering if you did it already, deciding what to do if a dose is missed, assessing performance, and deciding if memory aids are needed. There are many aspects of memory performance that are related to medication adherence. Some decline in aging, but others do not. It is important to note that decreased cognitive ability may not always lead to adherence problems, as many seniors compensate for normal cognitive declines very successfully. Some cognitive abilities are maintained or improved in older adults who are not suffering from dementia. For example, highly practiced tasks that are automatically processed show few declines. Also, the size of our vocabulary continues to increase throughout adulthood. Prospective memory, which involves remembering to do something, also increases. In fact, seniors, particularly 60 to 75-year-olds, are often superior at remembering to carry out an action in the future because they use reminders effectively. Both external and internal cues can be helpful with prospective memory. External cues include physical reminders, such as alarms, and visual cues. These can be very effective, but are used less often. Internal cues, such as mental plans and activity, include things like time-based cues. I will take my pill at 10 p.m. Or event-based cues. I will take my pill before bed. Event-based cues are generally more effective, but sometimes not when the routine is disrupted. Age-related losses in older adults not suffering from dementia also include a reduced speed of processing. Information needs to be presented in an organized and unhurried fashion. Losses can also include reduced working memory. Working memory allows us to juggle multiple pieces of information and to focus on a problem without being distracted. Older adults can be challenged when needing to combine instructions for different medications into a plan of action, or when they must integrate a plan of action into their daily activities. Older adults can display reduced source memory. They are more likely to forget where they learned something, even if they do remember the information. Some older adults will therefore make decisions about how to take their medications based on information that comes from unreliable sources, such as magazines and television. Reality monitoring is remembering that an action has already been carried out. It can be difficult to recall accurately whether a medication has been taken earlier that day, particularly if a well-established routine exists. It can also be difficult to determine if we actually carried out the action or simply thought about it. Blister packs and dosettes are particularly helpful to avoid doubling doses due to age-related decline in reality monitoring. Finally, research suggests that people adopt external memory aids because of their beliefs concerning memory, not because they believe their illness is serious. Therefore, education should focus on the idea that everyone needs memory aids, as well as on the importance of adherence. Patients' attitudes, beliefs, and preferences about taking medication can also impact adherence. Their general attitude towards taking medications may be negative, as in, drugs don't work for me. Or they may be overly positive, as in, there must be a drug that can solve my problem. In addition, patients' wants and expectations that a drug will cure their pain, or their wish not to have to take so many pills every day can impact medication adherence. These attitudes and beliefs, combined with a patient's knowledge or lack of knowledge about a medication, can lead to some difficulties. Patients may be unsure if medication is of benefit, concerned about risks in taking the medications, worried about the side effects that they might experience, confused over how or why to take a medication, and they may experience fear related to previous problems with the medication or problems experienced by a friend or family member. In addition to patient factors, there are also various medical and treatment factors that affect medication adherence, such as a patient's diagnosis. For example, the severity of symptoms. There are higher rates of adherence seen in patients with hypertension, hypothyroidism, or diabetes, while lower rates can be seen with silent diseases such as osteoporosis and hypercholesterolemia. There are also increased adherence rates among those with multiple diagnoses, for example, having been diagnosed with hypertension and hypercholesterolemia and gout. There is also increased adherence with add-on drug therapy due to previous experience taking medications for a condition. Depression can affect medication adherence in several ways. For example, people who are depressed are likely to amplify the side effects of medications, or to misinterpret symptoms of depression as side effects, leading them to stop taking the medication. Depression related to some medical conditions can go undetected, for example, depression post-stroke, and therefore reduce adherence if patients misinterpret their symptoms in this way. However, antidepressants, as prescribed by a psychiatrist, can improve compliance with refills. The regimen complexity can affect adherence. A complex medication regimen for a patient can include a high medication count, frequent daily dosing, multiple dosage forms, and additional usage directions. These complex medication regimens have been linked to a greater risk of medication non-adherence in some patient populations. Patient-provider relationships are important in medication adherence. Often, patients are provided little information about their medications, or the information is presented in a way that is difficult for older patients to interpret. For example, pharmacists often include a long, typed insert in the medication bag without understanding that information for older adults is best provided in list format. Pharmacists and physicians may overestimate how much information they provide, may rarely ask about side effects or other barriers to adherence, or may not recognize patients' low level of understanding or recall. For example, telling a patient to take one capsule 3 times a day may be confusing, but telling them to take one capsule at 8 a.m., 3 p.m., and 10 p.m. may result in better adherence. Finally, there are many system barriers that can reduce medication adherence. These include socioeconomic issues such as education, ethnicity, and language. In addition, lack of social support and low financial status can decrease adherence. Those without social support are less likely to be motivated to take medication or to receive reminders from others. Financial status can impact access to healthcare and medications, and patients may not be able to pay the medication cost or the copay associated with a drug plan. And finally, lack of or cost of transportation and impaired physical mobility can make it difficult for patients to attend appointments or to drop off or pick up prescriptions at a pharmacy. In addition to the various factors that can influence adherence, there can also be difficulty in the measurement of adherence. First, adherence can be determined through measures of medical consumption, such as pill counts. However, this can often be inaccurate or not feasible due to missing information from labels, variability between dispense dates and start dates, and when old and new supplies are combined. Patient self-reports can be used, and examples of these include the drugs tool, the MedTake test, or quick screening tools. Or electronic medication adherence devices can be used. For example, the MEMS, MD-Log, CompuMed. These can be helpful, but they can be expensive or not readily available. So determinants of adherence can also include measures of medication possession, such as refill records from community pharmacies. However, there are often inconsistent report designs, making this a difficult task. Electronic claims databases provide useful information, and they can provide medication possession ratios, which are reliable. For example, the days supply of the drug over the first year is divided by the number of days in the year. If the ratio is less than 1, this indicates lapses in prescription refills. If the ratio is 1 or greater, this indicates perfect compliance. Electronic claims databases can also determine persistency, which is the amount of time that the person remains on chronic drug therapy. A physician office electronic prescribing record can also give a prescription possession ratio, which is similar to the MPR. Given the various barriers to medication adherence and to its measurement, there was a clear need to develop a comprehensive and easy-to-use tool such as the SMAT. The SMAT assessment tool provides a comprehensive approach to determining a patient's ability to self-medicate. The scoring system included in the SMAT allows for an objective interpretation of the patient's results. The SMAT also allows the pharmacist to plan interventions with the patient, caregivers, and the healthcare team. And finally, the SMAT may help prevent medication mismanagement events that can result in hospitalization. Part B of this module outlines the self-medication assessment tool in greater detail. The SMAT includes 5 scales that measure the various abilities required for safe and effective medication self-management. The first is the functional scale, which is comprised of 22 items, with a possible 2 or 3 point score per item. This scale measures the sensory, perceptual, and physical abilities of the patient. Next is the cognitive scale, which also includes 22 items, with a possibility of 3 point score per item. This scale measures the patient's ability to make judgments, manipulate information, and interpret instructions. The recall scale includes 4 items per drug, with possible 2 point score per item. Information collected includes medication names, indications, dose regimen, and a description of the patient's own regimen. This scale determines if the initial medication instructions were understood and remembered by the patient. Next is the purposeful non-adherence score, with 3 items and a possible 4 point score per item. This scale looks at patients' experiences with side effects, belief in the value of medication to health, and their history of stopping a medication. And finally, the self-reported adherence scale has 4 items per drug with a possible 2 point score per item. This scale is the patient's assessment of their compliance to their own medication regimen. New tools and measures are typically evaluated in several ways in order to determine their usefulness, reliability, and validity. First, focus groups with pharmacists were held to ascertain opinions on the usefulness of the SMAT, its ease of use, the thoroughness of the assessment, and on their willingness to use the SMAT. The reliability and validity of the SMAT was then tested in a sample of patients admitted to the Moncton Hospital between 2006 and 2008. This sample had a mean age of 81.5 years, ranging from 65 to 99 years. Most had 1 or more years in high school, and regarding cognition, their MMSE scores ranged from 12 to 30, with a mean of 26, and their clock test scores ranged from 4 to 13, with a mean of 9.2. Validity refers to how well a measure assesses what it is intended to assess, and reliability indicates the consistency and accuracy of the measure. The SMAT scales have high internal consistency, meaning that the items within each scale address the same domain. The SMAT shows high inter-rater reliability. Therefore, there is a strong agreement between 2 pharmacists who independently scored the same patient. SMAT scores show high reliability, such that patient scores remain stable over time. In general, a strong correlation can be expected between the patient's results on the cognitive scale of the SMAT and their results on the functional scale and on the recall scale. And the recall scale can also be expected to correlate highly with the results on the self-reported adherence scale. During evaluation, a significant negative correlation was found between results on the cognitive scale and results on the Purposeful Non-Adherence Scale, as would be expected. Based on the study results, there is an expected correlation between increasing age and a decrease in functional score and in the cognitive score. Convergent validity indicates how well a new measure correlates to existing and reliable measures. The clock drawing test, or CDT, is a common screening measure used to identify dementia and other cognitive impairments. The CDT correlates with the functional, cognitive, and recall scales of the SMAT. The Mini Mental State Examination, or MMSE, is a common screening measure used to identify cognitive impairment and to monitor cognitive change over time. The MMSE correlates with the cognitive, recall, and self-reported adherence scales of the SMAT. The Cognitive Competency Test, or CCT, is used to measure cognitive performance within the context of everyday tasks. The CCT correlates with the functional, cognitive, and recall scales of the SMAT. The evaluation of the SMAT indicates the following. Post-test surveys yielded positive reviews by patients. For example, patients found that the directions were clear and easy to follow, and that the 45-minute testing time was not distressing. Patients also perceived the SMAT to be useful. The evaluation also indicates clinical usability, such that pharmacists were able to make recommendations regarding adherence aids and supervision required using the scores from the SMAT. Predictive validity has not yet been established. Further research is underway to determine how well scores on the SMAT predict long-term health outcomes. Based on ongoing testing and evaluation, the following conclusions have been made regarding the self-medication assessment tool. The SMAT affords pharmacists a multifaceted tool that can help determine a geriatric patient's medication management ability. The tool has strong patient acceptability. The scale is reliable across time and across pharmacists and has been shown to have acceptable validity. Scales with a stronger cognitive aspect relate well to measures of cognitive function. And the SMAT scoring system provides objectivity for clinical recommendations. The lead researchers and developers of the SMAT are Janice Irvine Meek and Odette Gould. The development of an assessment tool requires the dedication and contribution of many individuals and interest groups, including the research team and community stakeholders. The SMAT training video was produced and narrated by Monique Leblanc. This completes Module 1 of the SMAT training program. Thank you.